This is John. John is in recovery after a routine hernia operation, and the recovery nurse has asked me to come and have a look at John because she's not happy with him. Okay. So I'm making sure there's a safe to approach, and John, I'm just doing a gentle shake and shout, seeing if his conscious level is increasing with just by me touching him and talking to him. And there doesn't appear to be any response. I can see his mask is misting and the bag is emptying, but he seems to be making some funny noises. I'm just going to look in his airway with a head tilt chin lift, and again it's simply that. It is what it says on the tin. It is lifting his chin up and tilting his head back towards his body, and that seems to make his obstruction better. There is nothing to find in his airway. However, if I wished to and I saw something in his airway, I could either use Assessor McGill's forceps and remove the obstruction, or if I saw any secretions, I could use some gentle suction to remove any secretions. When we suction, we always do it on removal of the suction catheter, and we suction for no more than 10 seconds. And once we remove those secretions, the oxygen goes back on. I notice that every time I put his head back in the normal position, his obstruction becomes worse, and so I can supplement his airway by also doing a jaw thrust manoeuvre, which involves me placing the balls of my thumbs on his zygoma and my fingers behind the angle of his mandible and lifting his chin forward, and that seems to relieve his obstruction and the sound gets better. Every time I let go, the obstruction gets worse, so I need something else to help support this guy's airway. So I would move on to choosing an oropharyngeal airway, and they come in 3 sizes for adults, in 2s, 3s and 4s, which are green, orange and red. They have a curve, because that is the way they sit in the patient's mouth, and so they're sat there down in the nasal oropharynx, and they have a bite block so the patient can't bite and chew through it and make the obstruction worse. To size up the oropharyngeal airway, and I'll take green because I know that works on this mannequin, we measure from the angle of the mandible to the vertical distance of the incisors. So we can see that one's a good size. However, size 4 is much too large. Okay. How do we insert it? Again, we still need to support the head tilt chin lift. We invert the oropharyngeal airway. We insert the oropharyngeal, we rotate and locate, and that seems to stop the noise. Until. So the extra oxygen that we're now getting into his circulation and up into his brain, his conscious level seems to have improved, and so he seems to be coughing on the Goodell airway and the oropharyngeal airway, so we remove that, and we then again check his airway and look for any secretions or any vomitus. I can see some vomitus in the back of his mouth, so again, gently sucking what I can see along the buccal mucosa and sucking as I remove the catheter. Unfortunately now, I've took his Goodell airway out, he's still making these gurgling sounds, and again, every time I let go of his head tilt chin lift, the gurgle gets worse. So then I'm going to move on to using a nasopharyngeal airway. Nasopharyngeal airways again come for adults in sizes 6, 7s and 8s, and a good size to use for a normal male would be a size 7, normal female size 6, very large male a size 8. Again, they have these fixed plastic flanges on which prevent the nasopharyngeal airway going too far down. They need to be lubricated, and we check the size not against the little finger as we have done in the past, but certainly by checking the beveled edge against the size of the patient's nostril, and also then checking the length by using the tragus of the ear to the septum, and that looks like a good size. So now it's lubricated, we generally choose the right nostril, so that it's generally the larger nostril in most people, and with a gentle rotation insert that airway. If we meet any obstruction, we then stop, and because then there may be some obstruction from a nasal polyp or from a deviated septum or from a foreign body, and obviously it may cause more harm than good. So in that instance you would remove the nasopharyngeal airway and go to a smaller one. This nasopharyngeal tube, I know, fits this mannequin and fits nice and easily. Once that's been sat there, we replace the oxygen and reassess. Obviously we would avoid using a nasopharyngeal airway in anyone who had a head injury. The whole purpose is to get oxygen delivered to the brain but not directly to the brain, and therefore we will avoid it in a base of skull fracture or suspected base of skull fracture. Patient seems to be breathing quite nicely, mask is misting, constantly reassessing, looking at his airway, looking at his chest movement. However, John seems to have gone quite quiet and his mask seems to have stopped misting. So now I need to go back to the top and reassess. And again, gentle shake and shout, John, John, and there doesn't appear to be any response. So head tilt, chin lift, again looking in his airway, making sure that there's no other obstruction or vomitus. And I'm going to look, listen and feel. And because we're healthcare professionals, we can feel the pulse and listen to the airway and look down the chest at the same time for 10 seconds. 6, 7, 8, 9, 10. There is a pulse, but there is no breathing. So can I have some help, please? Yeah. Grand. This chap's had a respiratory arrest. Ah, that's perfect. So what I'm going to use is this bag valve mask, and it does what it says on the tin. There is a bag with a valve and a mask. This connects to the oxygen supply here, and again we deliver 15 litres of oxygen via this, and this can deliver up to about 85% oxygen. The easiest way to hold the mask is using the C grip, so using your thumb and forefinger to hold the mask. Place that the nose area over the nose, and this sat on the chin. Using that C grip, then use the other fingers to keep the bony areas of the mandible, as otherwise if you push up on the soft part of the chin, this could make your obstruction worse. So keeping your fingers on the bony bits of the mandible, still trying to maintain that head tilt chin lift with a little bit of jaw thrust, pulling the mandible back, applying the pressure and pulling the face into the mask, not the mask down onto the face. And it's gentle squeezes with the bag. And again, this is a 2 litre reservoir, a 2 litre bag, so the patient doesn't need all that. We just need to be able to see the chest rise and fall, and we then squeeze once every 6 seconds. You can use a 2-man technique, so you can use a double C grip and use again using your fingers on the bony parts of the mandible and help pull the jaw, keep maintaining that head tilt chin lift while your assistant gently squeeze the bag, watching the chest rise and fall. I would much rather be able to maintain the airway like this successfully than try bagging vigorously, or certainly try any other adjuncts. Being able to maintain someone's airway like this, even with a 2-man technique, is what's going to save their life.